Wow, what an insightful panel discussion. Thank you again, Mr. Shaukat Ali Khan. And ladies and gentlemen, don't you just love the knowledge transfer that these summits by CXO Global enable? Let's now move on to a very unique case study by Dr. Asad. This case study is going to be about challenging conventional medical wisdom in the age of data and disruption. Without further ado, let's begin. The floor is yours, Dr. Asad.
Okay, Assalamu alaikum, good morning, everyone, or whatever time zone you're in. My name is Asad Mia. I am chairing the Department of Emergency Medicine at the Arkan University in Karachi. I am also directing Critical Creative Innovative Thinking, or CCIT, which is a first of its kind co-innovation and incubation hub at the Arkan University in Karachi. The reason why I was looped into this session today is really because of my work in innovation, creativity, and entrepreneurship, healthcare related, as well as outside of healthcare. And so today's talk is really encompassing the innovation and entrepreneurship work of mine at AKU. I am a doctor and a clinical researcher by my training, and innovation and entrepreneurship are areas that I have learned after moving back to Karachi and working at it for the past few years. So I'm unable to see the audience or hear anybody, but I'm assuming that people can hear me. I'm going to share my screen now, and I'll just get into my presentation. Host is disabled participant screen sharing. May I please share my screen? Okay, great, thank you. Alrighty. Okay, so just move this part. Okay, so the title of my talk is Challenging Conventional Medical Wisdom in the Age of Data and Disruption. So I was looking through the schedule and the other speakers and the content of this really interesting conference, one-day conference. A lot of talks that you've heard or will hear over the course of the day are predominantly geared towards high-tech and high cost innovation, healthcare related innovation. And what I would like to do over the next several minutes is to flip this on its head. And I want to make a case, or make the case, for low cost and low tech health innovation in a setting that does not have the innovation ecosystem or culture established as yet. And so rather than focusing on device-based health innovations, what my team and I have done at AQ and beyond is promotion of an innovation culture that encourages simple approaches by students of healthcare, as well as interdisciplinary folks, both students and practitioners. And so the systems level approach to health innovation, either tech or non-tech, encourages pre-ideation, ideation, and early stage incubation of low cost and low tech health and otherwise innovative, creative, and entrepreneurial ideas. And that's essentially the abstract, the gist of my talk today. And so I'm making the case for this in the age of innovation. So data and disruption, sure, but it's really making a case for innovation and low cost and low tech innovation. I have nothing to disclose, just a question for you to reflect on. And just based on your own thoughts around this, what do you think will be most impactful for global health? Do you think it's A, service, clinical service, B, education, C, research, or D, innovation? So just think about it as I progress with my talk. So what are the outcomes or the learning outcomes or learning objectives for my session now? I want to make a case for health innovation by delving into the disease burden or the immense disease burden of Pakistan. And I'll be belaboring the point. I'm assuming a lot of people will be talking to you about the need for this. So will I be repeating what others are going to be saying? No, not necessarily. I'll just make a very targeted case for health innovation and why we need to think about low tech and low cost healthcare innovation. I will then, the bulk of this talk is about our experience of health innovation at AKU and beyond through our simple processes that we've implemented over here. And if there's time, I would like to just discuss perhaps one major challenge that we felt in this, and then what could be done about it. I'm going to end with one or two really interesting things, exciting things that we've been working on more recently. So as I said, there's an immense burden of disease, and Pakistan, like most low middle income countries or LMICs, has a healthcare system that's rife with problems. And even if I were to not delve into specific issues, I think using innovation, creativity, and entrepreneurship, or ICE, as potentially meaningful tools for addressing these myriad problems would be the way to go. But anyways, bear with me. So currently we rank number 3 in the world for under 5-year-old child mortality. Under 5 children are dying in huge numbers. If you think about neonates or babies under 30 days, that's even worse. So we're probably in the top 1 or 2 in terms of neonatal mortality. We have pretty high maternal mortality, which means pregnancy and childbirth related causes of death in women. That means that of the reproductive age group, so 15 to 45 years of age, those women are dying in huge numbers across the nation. We suffer from what is typically described or routinely described as a triple burden. We suffer from communicable or infectious diseases. We suffer majorly from non-communicable diseases now, which includes your heart disease, so cardiac issues, things like diabetes, and then we've got major psychiatric issues, and then we've got trauma as another major issue, because we don't have very good trauma care systems in place or trauma prevention systems in place. We have a lot of trauma and injury related death and morbidity from that. And then huge surgical inequity between just rural and urban areas, lack of access in rural areas. So all of these issues combine and cause a lot of impact or a substantial burden on individuals, on citizens, on health systems, on governments, both at the provincial and federal levels. This, again, makes a point for why we need to really seriously consider health innovation across the board, not just health tech, but also other paradigms of health innovation, creativity, and entrepreneurship. So why even bother to innovate? I'm still going to make a point over here. Okay, so this is what you're seeing. This is a bit of a dated slide, so apologies, but I think this is a stark reminder of what we're dealing with. So what this graphic shows you is the total health expenditure per capita, and what I'm comparing over here is the US versus Pakistan. So somebody might argue, well, this is apples versus oranges, and it's not a very good comparison. But just bear with me. Look at the numbers over here, right? So look at the US in orange over here, and look at the total health expenditure per capita, which is kind of going up and up and up over this time period that's shown over here. And look at Pakistan; it's kind of flattened. Anyway, it's flattened all across, right? So it's hardly gone up over this particular time period. So what's the point over here? Okay, so regardless of what the total health expenditure per capita is, the money being spent is it reflected in better health outcomes? Just reflect on that question. Think about the US. Think about the US during the pandemic, and think about Pakistan as well, right? So if we go further on this, I'm going to go off on a tangent and it might be a treacherous path. But anyways, the point is that all nations, regardless of total health expenditure per capita, need to innovate. So your costs need to be brought down if they're very high. And if you're not spending enough, you need to go up on that. So, okay, so what about de novo healthcare innovation? De novo means that something that's coming from within, from that particular group or that particular population, versus something that's being imported from outside. So it's not a top-down approach, it's really a grassroots approach, de novo healthcare innovation. So LMICs are low middle income countries, Pakistan as a case in point, we're unique. Why are we unique? We shouldn't keep bashing ourselves on the head because of our really horrendous performance in terms of healthcare, because although we are resource limited, we are not innovation limited. We have huge potential to innovate. And we've got this really intriguing potential to utilize Jugaad. Now, Jugaad is not just a funny word here. I'm not making fun of ourselves because we have Jugaad potential. Jugaad is adaptability, is improvisation. It's not just making do with what you have. It's actually utilizing what few things you have and putting them to tremendous benefit. And Jugaad could be done in a very systematic way. And that's what we've learned through our processes at AKU and beyond or past AKU as well. So I'm going to make a huge case for Jugaad innovation through these kinds of processes. I love this quote. This is from the book Turning the World Upside Down by Lord Nigel Crisp, who's one of the former CEOs of the NHS in the UK. So he says in the book that rich countries can learn a great deal about health and human services from poorer ones. Combining the learning from rich and poor, countries can give us new insight on how to improve health. So that's the crux here, that we, being in a low resourced or low middle income country setting, we have utilized paradigms, or we've demonstrated things that could be utilized by high income countries. And this could truly impact global health. Okay, I'm going to move into our own experience of instilling innovation, creativity, and entrepreneurship, or ICE, into AQU's DNA. Quick story. When I moved back to Pakistan about 8.5 years back, after training and practicing medicine in the United States, I was frustrated because I was coming from a very high income setting and high resource setting, high tech, high resource medical system setting, to a low tech, relatively speaking, and low resource setting, and you don't have health insurance paradigms of the same manner that exist elsewhere. And so it was frustrating. How do you work over here when you are seriously limited in what you can do? And another thing, interestingly, I realized was that the emphasis over here, whether it's on students or on trainees or on faculty, and I'm talking about generally, that emphasis tends to be on what to think versus how to think. And it's a very top-down approach that you tell the student or the learner, okay, this is what you need to know, versus enabling them to figure out what is needed. So critical thinkers, right? And along with that, there's an increasing standardization of medical systems, even over here, with evidence-based medicine and EBM protocols being very protocol oriented over here as well. But there's this uber emphasis on data. And I'm not denying data. I love my data. I am a data person. I am a researcher, clinical researcher. So I love my data, but it's very well known that when you constantly emphasize on data, there is an inhibition of your critical thinking, creativity, and imagination, which in turn tend to inhibit your innovation potential. So all of this tends to lead to this tunnel vision within the medical world. So where do we need to be? We envision a place in Pakistan that where medicine actually prospers through non-hierarchical approaches, which means that there's no junior or senior, there's no teacher or student. Everybody is there to solve problems. And it's a mixed team. So it's a transgenerational team, the young and the old working together, and interdisciplinary and very multidisciplinary. So the problems of healthcare over here in Pakistan cannot be solved by doctors and nurses or healthcare practitioners alone. It's very clear. And this is the same narrative globally. So you need your techies, your engineers, your business folks, your humanities persons, your social scientists, and whatnot. Even the newer disciplines that are coming up, right? AI, machine learning, data science, and so on. So all of these folks collectively, including healthcare practitioners, obviously, is what we want to encourage and promote. And that's where my Innovation Incubation Hub, Critical Creative Innovative Thinking, CCIT for short, comes to the forefront. And so what has been the impact of this Innovation Incubation Hub at and past AKU? And I describe our journey over the past several years. And we've done a lot of things, and I'm not going to bore you with each and everything. So we've done several things. Each of these columns over here represents a different implementation or different initiative project, if I may. And we've done Ignite sessions, we've done incubation cohorts, narrative medicine, research and communication, and gamification as well. Several things have been done. I'm going to focus on the last column over here, which are multidisciplinary or interdisciplinary hackathons for healthcare and going past healthcare as well. We've done around we've done 7 major hackathons, but we've done close to 10 or over that. If you include our many hackathons, we've involved or incorporated thousands of participants actually through a hybrid model. So for initially it was face-to-face hackathons, and then we went hybrid, and then we went entirely online or digital hackathons. And we've really learned a lot from the hackathons. So here's just 1 or 2 examples from our earlier hackathons. This one I really enjoyed a lot. I really loved this one because in this case, you could see in this figure that's shown that children were brought into AKU because they were asked to identify problems of children's hospitals or pediatric spaces, because the clients are children where the pediatric space is concerned, right? So healthcare or children's hospitals. So we involved them in this hackathon or pediatric hackathon, and they came up with their versions of what low cost or low resource children's hospital should look like, and was a lot of fun working with these children. This was the first hackathon that we did, the one on the left, which was on emergency medicine, because I am an ER doctor. So we brought in a hackathon paradigm from MIT. The team from MIT Hacking Medicine Initiative were great partners of ours. And so a shout out to MIT Hacking Medicine Initiative for really getting us started on our hackathons about 6 or 7 years ago. And there's been no looking back. We've done close to 10 utilizing the same hacking medicine initiatives, hacking paradigms. And here's a summary slide of the 7 major hackathons we've done at AKU. You could read about these through our papers. We've published all of our data, and these are all original research articles. You can find the references at the bottom of the slide over here. But we've also covered all of this, summarized this in a chapter in MedJack, which is the book I'm going to mention as the major reference of this at the end of this. I don't know if you can see this, but you can't see this. Anyways, so I want you to focus on just a few of these points over here. The majority of the the first red bar over here is showing you that the majority of the hackers tend to be younger individuals, less than 30 years of age. And that's been described globally as well, that the innovators and entrepreneurs in your establishment, even healthcare, where healthcare is related, is concerned, even medical university or a school of nursing or whatnot, the younger lot, your students or your residents, they're the ones who get really excited by these kinds of events. And so the majority tended to be these young individuals. Another great data point for us is that women innovators and entrepreneurs get really interested and excited. And you could see the majority in a lot of these hackathons were actually women, and younger women for that matter. And then you can tweak the hackathon so that you can get non-medical folks to come and hack at these interdisciplinary events. And I'm not going to get into details. I don't have time, but this blue arrow over here shows a transition or a tipping point for us, because prior to that, the first 2 hackathons, we did not have an incubator in-house. After that, we actually started incubating a lot of those really interesting ideas. Not each and every team would get incubated from the hackathon, but a few of them that really were serious and committed to developing that idea further, and we would incubate them in-house, and we've iterated upon our incubation cohorts as well, and that's covered in our book MedJack. The arrow over here, green arrow over here, Jugaad Innovation Challenge, was really interesting, was really cool, because this was around COVID-19. And we actually did this entirely virtual hackathon to come up with solutions to problems that people across the globe had identified where COVID-19 was concerned. And this was a virtual hackathon. And then the last one that we've done, the most recent one, has been from for the Brain and Mind Institute of AKU. And this was for student mental wellness or student mental health related hackathon. So hacking problems around student engagement or student mental health. And this was really interesting because we involved students from all campuses of AKU. AKU is a global university, and we are on 3 or 4 different continents. And so it was a very global kind of a hackathon for AKU. Okay, just one example of what you can do from a hackathon from a hackathon-based innovation to incubation and beyond. One of the problems that had been identified from this, that had been identified by this team at our first hackathon was that if a baby stops breathing and then a tube is put, then the bagging is done by the parent, mother in this case, because ventilators are not readily available. And this is an example from a government hospital in Karachi. And this is a terrible case, because terrible situation to be in, because parents should not be bagging this particular, their own child. It's just unethical. But when there's no ventilator available and there's not enough medical folks, you don't have enough healthcare folks available, then what's going to happen? That the parent will have to pump oxygen into this baby through this bagging device. So what this team did was that they hacked over a weekend, and then they came up with this very simple prototype. They engineered this over a weekend of hacking, and they demonstrated that this automating the bagging, manual bagging process could lead to better outcomes. And this particular hack was picked up by the Aachen Development Network's Digital Health Resource Center, DHRC. Salim Sayani is the lead of that. He's also the chair of the innovation committee at AKU. And his team then prototyped this in their innovation lab, and then patented this particular device. So it's been patented both in Pakistan and in the US, and clinical trials are ongoing. So this is just one example of several ideas that have come through our various hackathons. So what is a spectrum that we're looking at? We're looking at the spectrum where there's pre-ideation and ideation, and then early stage incubation. And pretty much around this, from pre-ideation, ideation to early stage incubation, is where CCIT is really functioning within our medical college and School of Nursing, and within our medical ecosystem. And we are an academic lot, but then once a team who's showing a lot of potential, or a startup that's showing a lot of potential, then we can hand them over to other entities at AKU, within AKU, because we have that potential. And we also have entities such as Accelerate Prosperity that are working very closely with us, and we can send these particular startups to be accelerated through AKU centric as well as non-AKU organizations, including Nest.io, and so on. So from Nest, yeah.
Sorry, Asab, your time is exceeded. If you can please wrap it up.
Yeah, last slide, last one or two slides. Okay, thank you
very much.
Yeah, no problem. So, okay, so what are the challenges? What's the major challenge? Okay, so novel events are very challenging in academically traditional places. So the currency tends to be research and publications. And so when you're implementing a thought process of this kind, or an intervention through an academic place, you might not have the evidence that it will work. So you're kind of flipping it on its head, and you still want to go ahead with the implementation. Make your mistakes, learn from it, and then publish it through evidence that you've garnered. Funding and other logistics, always an issue. And who are the stakeholders for the startups in an academic healthcare institution or medical university or a school of nursing? Very interesting thoughts or problems to work through. So it really points towards a culture or ecosystem of innovation that's lacking, and we've constantly been building that up. And these are some of the partners that we've worked with within AKU, different departments outside of AKU. Some of the entities that I've mentioned, like AKDN, Nest.io, we've got the NICs we've been working with, then internationally Ryerson University and Harvard, MIT, and then within Pakistan, NUST, LUMS, Habib and Ziauddin. We're working on very interesting things currently: human-centered design thinking to solve complex problems, the CCIT way, design thinking, a lot of fun. And then this is the last slide. We've come up with an innovation benchmarking tool for your organization, and we have the potential of certifying your individuals for their innovation potential. If you're interested, get in touch. We would be happy to actually tell you more about this. And why is this the title, Challenging Conventional Medical Wisdom? Because traditional mindset would probably get you to focus on research first and then getting that evidence before you do any innovation. We are flipping this on its head, and we're saying disruption or other kinds of innovation is the way to consider when the morbidity and mortality is really getting us to rethink how we're going to do this for healthcare within Pakistan and other low resource settings. And that's it from me. This is the book. Medjack.net is the website, and you could learn from it, teach from it, and do these processes even better than us. Thank you.